A 67-year-old man with a history of hypertension and coronary artery disease presents to the ophthalmologist complaining that for the past month, he has noticed decreased vision on his right side 2 or 3 times a week. Each episode lasts about 20 minutes and is accompanied by a severe retroorbital headache. During the episodes, he is unable to read and bumps into objects on his right. Yesterday, he experienced the same visual loss, which has not resolved. Automated perimetry visual field testing reveals the pattern shown in figure with areas of visual loss in black. What is this visual field defect? The defect is a right homonymous hemianopia, likely caused by a stroke. Homonymous hemianopia is a visual field loss in the same halves of the visual field of each eye. The patient's symptoms suggest that he has experienced a number of transient ischemic attacks. Transient ischemic attack, or mini-stroke, is caused by a brief blockage of blood flow to the brain. The classical definition of a transient ischemic attack is a vascular event that causes neurologic deficits that last less than 24 hours. Clinically, it is defined as a neurologic deficit that lasts less than 1 hour in the absence of abnormal imaging findings. What is the pathway from retinal photoreceptors in the retina to the visual cortex? Photoreceptors, rods and cones, synapse on bipolar cells that synapse on ganglion cells in the retina. The photoreceptor rods are involved mainly in low light and peripheral vision, whereas the photoreceptor cones are mainly involved in color and central vision. The optic nerves travel posteriorly and merge to form the optic chiasm. In the chiasm, nasal retinal fibers from both eyes cross, while temporal lateral retinal fibers remain uncrossed. Nasal hemiretina fibers carry information from the temporal halves of the visual fields, while temporal hemiretina fibers convey information from the nasal halves of the visual fields. As a result of this partial decussation, the entire left half of the visual world is projected to the right side of the brain, and vice versa. Once past the chiasm, the retinal axons enter the optic tract and synapse on the lateral geniculate nucleus of the thalamus. Axons exiting the lateral geniculate nucleus fan out posteriorly through the cerebral white matter as the optic radiations. The inferior part of the optic radiation carries information from the inferior retina or superior visual field, travels briefly through the posterior temporal lobe as Meyer loop, then continues through the parietal lobe to the occipital lobe. The superior radiations carry information from the superior retina or inferior visual field and travel directly through the parietal lobe to the occipital lobe. The optic radiation synapse in the visual cortex of the occipital lobe near the calcarine fissure. The superior radiation synapse superior to the calcarine fissure, and the inferior radiation synapse inferior to the fissure. Where along the optic pathway may a lesion be located to give this homonymous hemianopia? A lesion in the left optic tract or lateral geniculate nucleus can cause this defect, as may a large lesion of the optic radiations or a lesion in the left visual cortex. An ischemic stroke involving the posterior cerebral artery can cause homonymous hemianopia. The posterior cerebral artery supplies the occipital lobe. What visual field defect would a lesion in the right temporal lobe cause? The inferior optic radiations, Meyer loop, travel through the temporal lobe. A lesion to this area shows a left upper quadrantic anopia pie in the sky, as indicated by lesion in the figure.